Hello, my name is Antonio. I'm a UK and US trained ear, nose, throat surgeon and neurologist. I do get a lot of calls from my colleagues, particularly general practitioners, about a particularly distressing symptom called tinnitus, which is generally sound perceived by the ear, which is not generated by an external source. Now, especially in the light of concerns regarding airborne infections, putting both the patient and the healthcare giver at risk, they're looking for means of safely evaluating these patients so that they can be given the correct treatment. Before I go into specifics, I'd like to go through the current thinking in a very simplistic way of how tinnitus is produced, and this will involve how we perceive sound. Sound generally is compressed air, which impacts on the drum and the middle ear structures, whereby these sound waves are converted to mechanical energy. This mechanical energy is amplified by the ossicles and sent through the oval window to the cochlea, where these signals are converted to electrical signals, which is the language of the brain. These electric signals, along with other signals, goes to different parts of the brain. That for sound goes to an area of the brain called the temporal gyrus, where the sounds are collected and sent to other parts of the brain for processing. Now, there are different areas of the brain involved. The ones of note are those involved in cognition or learning. So that's the part that you need for concentrating on things, trying to pick up new information. Also goes to the areas involved in emotion, fear, anxiety. As you can imagine, every sound needs to be evaluated for its content. So the same sentence may mean different things depending on the context in which it's given, which is why that's relevant. In the years gone by, sound is very important for us to know whether there's danger approaching. So you can imagine we'll go to alertness centers, which is responsible for sleep. Also related to those involving our vital functions, such as the pulse rate and also the respiratory rate. All these structures send back messages to the sound center, and they have a feedback loop, which may well be accentuating the noise perceived, or they may well suppress it. In other words, we now believe that all these centers work in cahoot together, and tinnitus is basically a sudden change in the sensitivity of the hearing center. And various treatments, especially the mind therapies, are geared towards breaking this loop. Now, with that in mind, you can see that you can have air-based causes for tinnitus, in other words called otitic tinnitus, or non-air generated causes, because the ear is surrounded by a lot of other structures like blood vessels, which it actually sits on, some nerves. It's also close to the jaw joint, and also the brain itself contains other things which gives off electrical signals, and this may well play a part in the genesis of tinnitus. In terms of the history, one wants to know what type of tinnitus is being produced, because you can have low frequency noise, like a humming noise, or a high frequency whining noise, or a mixture of both. Some may well produce a machinery noise. Some produce a pulsatile noise, which may even be audible to another observer, it's called objective tinnitus. But by and large, most tinnitus are subjective, whereby it's only the patient that perceives these sounds. Now, you want to know whether the tinnitus is there all the time, or it only comes during certain times, such as when it's quiet or when they're not concentrating on other things, which may well help your management. If it's brought on by anxiety or the patient is depressed, and in some cases, you may want to do a formal assessment for depression, and there are various questionnaires which will help you in assessing patients along these lines. In addition to that, you want to know whether the environmental changes like loud noises, a temporary loud noise may well induce a transient or temporal threshold shift. But if the noise is persistent, especially in a work environment like a printing press, this noise may be permanent, and the patient may well be seeking compensation for the permanent hearing loss and tinnitus that they may be experiencing. You also want to exclude other pathologies in the ear, like a discharging ear. Vertigo or dizziness may accompany tinnitus, and that's something to bear in mind and part of your history taking. You want to know if there's associated pain, and general things that would point you to an ear cause for the tinnitus. If there are obvious cranial nerve abnormalities, this may well reflect on patients with postacute tinnitus, whereby patients with glomus may well present with postacute tinnitus, which may be accompanied by hearing loss and cranial nerve abnormalities, and those are things to bear in mind. And in terms of hearing loss, you can infer that by asking them to if there's any change when they listen to a phone, or if they feel that they're unable to hear a doorbell, things along those lines. And that may well give you a rough idea of whether the patient has hearing impairment. Other things you can do, you can ask them to rustle paper on their ear, or see if they can rustle their fingers to see if they feel the hearing is the same on both sides. Asymmetrical hearing, as hearing different on both sides, may well prompt you to request for an MRI scan. Apart from trauma, you want to know what medications they're on. Some of them may be on antidepressants, which may help some patients with tinnitus, but it may actually make tinnitus worse in certain patients. Hypertensives may cause tinnitus. Aspirin and non-steroids also can cause tinnitus. So your history should involve medications that are taken. You want to know if there's a family history of brain tumors. That may well suggest that there are other investigations that are very relevant for you to do. In addition to your hearing test, you may want to do a scan for these patients. You may observe the patient having nystagmus. You can ask them to look in different directions, may well observe the eye movements if you have the benefit of the video consultation. You could also get them to demonstrate various facial movements or shoulder movements, eye movements, to try and show if they have any obvious cranial nerve abnormalities that you may pick on. You could ask them to stick their tongue out for one, which would give an impression of whether the 12th nerve is involved in their pathology. And taking a history, if you don't find anything of note along those lines, then you can make decision whether further investigations other than a hearing test is relevant in your cases. But I would want to do an MRI scan if I notice there's asymmetrical hearing loss. But if the hearing is the same on both sides, the MRI scan may not necessarily reveal any pathology. I hope these would be things that you find helpful in our evaluation of these patients with tinnitus. In terms of management, there are various things you can do. You can ask them to see a hearing therapist if you can find nothing sinister going on, especially if they got symmetrical hearing. If they do have a hearing loss, a hearing aid may prove helpful. If they don't have a hearing loss, things like cognitive behavioral therapy or mindfulness, some people will find beneficial. Some patients would have their symptoms relieved if they have a background sound going on. But in those with surgical conditions like otosclerosis, which would typically have a conductive hearing loss, surgery may well help those patients, as with some patients with glomus jugular. However, you need to bear in mind that surgery in itself can cause tinnitus. Many thanks.